Alright guys, welcome to another video lecture. This time we're going to talk about DIC, or disseminated intravascular coagulation. um, by now this chart should start to look familiar to you. You have your extrinsic pathway and your intrinsic pathway. This is for damage caused outside the body, and this is for damage caused within the body. This extrinsic pathway is tested by the PT, meaning that it follows this pathway through looking for a clot. This part of the pathway here is what's known as the common pathway because they both lead to this section. This is the PTT test, and it's testing the coagulation ability through this pathway. Up until now, we haven't discussed anything to do with abnormal PT or PTTs related to the overall lack of coagulation proteins. Within disseminated intravascular coagulation, you have an antagonist. Something is causing the coagulation cascade to begin, and it's caused by tissue damage within the vascular system. This could be septicemia or any number of things that's covered in another slide a little further down. But what you're dealing with here within disseminated intravascular coagulation is a depletion. You have a depletion of your factors, your fibrinogen, your factor here. Everything is becoming depleted because you have a constant active coagulation state going on within your body. And your liver, which manufactures these factors, just cannot simply keep up. This is just a slide that demonstrates all the subjects that'll get covered a little further on. Within the coagulation system, you do have your factors leading one to the other, to the other, to the other, eventually until you form fibrinogen, or a fibrin clot, which is cross strands with platelets, as we've discussed earlier. But within that coagulation cascade, I wanted to kind of bring your attention over here to the inhibitors. The inhibitors, which are listed in this little box here, are the factors within the coagulation cascade that put a limit on it, or essentially regulate it so that your whole body doesn't turn into a clot. Your body needs to be able to activate the process for sure, but or stopping the clotting process is just as important as starting it. Furthermore, once you do have a clot, you eventually have to digest that clot to allow new tissue growth and repair, and that's known as fibrinolysis. Okay? These are the chemicals that are involved in breaking up that said clot. Fibrinolysis is started by plasminogen activators. Plasminogen is the chemical that will begin to break that down, and they have their the fibrinolysis also has its own inhibitors, the alpha-2 antiplasmins and alpha-2 macroglobulin. As you can see here, inhibitors on the left, activators on the right. Plasminogen will turn into plasmin, which dissolves fibrin into what's called fibrinogen degradation products. And this is what we look for in the laboratory here to determine whether there's a fibrinolysis process going on. When there is, and the fibrin does, when that fibrin clot does begin to break up, it'll break up into fragments. Uh, and this fragment, the most popular of which to test for is D-dimer, can be found in the laboratory. This is a photo of a fibrinogen strand being broken up into its various fibrinogen degradation products. The FDP screen, we used to do this more uh, uh, in older times or back in the day, but it essentially searches for those individual components rather than fibrinogen itself. Getting back to DIC, you have a whole host of triggering mechanisms. Anything essentially that can start up coagulation can put you into DIC. But if you notice, many of these things here are chronic conditions. And so it's a process of depletion um, that happens. Uh, During this process of widespread fibrinogen formation throughout your body, you're going to decrease your platelets, you're going to prolong your PTT, and you're going to lower your fibrinogen, obviously. Fibrinogen degradation products and D-dimers will be present. And if you remember back to your RBC morphology, the fibrin strands in the blood will tear the red blood cells and form schistocytes. So you will see that morphology on the blood slide. How do we stop this? We got to remove the source of what's causing the coagulation cascade to begin with in the first place. And even though these folks are bleeding out, you will sometimes give them heparin. Why? Heparin's an anticoagulant, and it'll slow down the coagulation cascade and allow your liver to catch up and manufacture sufficient clotting proteins. This is a diagram of all the various things that can cause DIC and how they're activating the coagulation cascade. Different antagonists will begin the cascade at different portions in the graph here. Schistocytes, obviously, here we have as a result of fibrins grabbing these, remember, fibrins grabbing these red blood cells, stretching them and ripping them, tearing them, and producing this morphology. So if you see this on a peripheral blood smear, it would be interesting for you before you call schistocytes to maybe look at what the coagulation history is and what we've reported out in the past. So DIC is really common, but it's not an actual disease. It's a secondary disease from an underlying cause. In blood bank, you will find that you give these people a lot of products, and they can be helped by low molecular weight heparin. However, you can cause the fibrinolysis process to begin in the absence of DIC. So that would be primary fibrinolysis, but nobody really knows what the initiating factor of that is. You will see similar lab results to DIC, but not D-dimer. Thrombophilia, love of forming a thrombosis or clot, can be hereditary or acquired. You're going to form thrombi, a deep vein thrombosis, pulmonary emboli. You're essentially in a hypercoagulation state. Uh, you can get that from venous thrombosis is also from having a resistance to protein C. Remember, protein C and factor V Leiden are inhibitors of the coagulation cascade. So if you have a resistance to said inhibitors, it will allow the cascade to keep moving forward, um, and you'll be in a hypercoagulable state. Same thing with deficiencies in protein C and protein S. You'll tend to form clots more uh, easily because you don't have those inhibitors present. Um, that's the hereditary portion. Your antithrombin 3 deficiencies, C's and 5, Leiden and S. All of these are hereditary and produce a hypercoagulable state. On the acquired end of things, you can have an antibody, a cancer, or several other disease states will cause a hypercoagulable um, condition. How can you treat that? Well, you can go for your intrinsic pathway with heparin or your extrinsic pathway, which is Coumadin. You can use clot busting agents like streptokinase, urokinase, and TPA. We also used to use snake venom diluted a long time ago when I first started, but TPA is a recombinant DNA production of that snake venom. I don't believe it's the exact same molecule, but it's very similar. Um, if the coagulation cascade is we're targeting the initial platelet plug, we can use agents like aspirin, Plavix, or inhibitors. Um, but if you do use Coumadin or heparin, they do not come without risks. You can bleed, skin necrosis, although I haven't really seen that much myself. And if you do end up taking too much oral anticoagulants, you can take vitamin K because if you go back to your coagulation cascade, vitamin K is a coenzyme that kind of helps that coagulation cascade move forward. So by giving them additional vitamin K, you're helping to counteract that that blood thinning. Low molecular weight heparin or unfractionated heparin um, can be used to try and reduce the amount of coagulation going on. As I previously mentioned, it can help with hypercoagulable states as well.